And good evening, everybody. This is Dr. Bill Tulo, Medical Director of Oculus, and I'm really excited tonight to welcome everyone to Oculus's clinical webinar series. Tonight, we have a special guest, Dr. Michael Belin. The title of the presentation is Screening for Refractive Surgery, Optimizing Clinical Use of the Belin Ambrosio BAD Display. Michael Belin attended Northwestern University, majoring in biomedical engineering, and received his medical degree from Rutgers Medical School. He completed his internship and residency at the Albany Medical College and his fellowship in cornea and external diseases at the University of Iowa. He subsequently completed, by invitation, a traveling fellowship from the Royal College of Surgeons of England Foundation. Dr. Belin is Professor of Ophthalmology and Vision Science at the University of Arizona Department of Ophthalmology. He's past president of the Cornea Society and vice president for international development. He's a fellow of the Royal Australian and New Zealand College of Ophthalmology and past chair of the AUPO Fellowship Compliance Committee. Dr. Belin is a recipient of the AAO Honor Award, Senior Honor Award, Academy Service Award, Achievement Award, and Lifetime Achievement Award. He has published over 180 peer-reviewed articles and presented over 250 papers at major medical and national international meetings. With no further ado, I want to welcome Dr. Michael Belin.
Thank you. So, as Bill said, what we're going to be doing this evening is talking about screening for refractive surgery, and particularly the optimal use of the Belin Ambrosio, more commonly known as the BAD display. Regardless, usually, of what the topic is, I always start with some background and some history. A couple of points. More information is not always better. Very often I get sent clinical information on patients, and there's 4 or 5 different instruments. There's Placido, the Scheinflug, there's 2 different type of OCTs, and very often the information's contradictory, particularly if you're using a Placido and a tomographic device. So I usually tell people there's really no reason to look at multiple images, multiple machines. Realize that the BAD display is designed for preoperative screening. What does that mean? Well, all the parameters are based on normal eyes. It tells you when an eye deviates from normal. So it is not appropriate, and we're going to discuss this later a little bit, but it's not appropriate for surgically altered eyes. Those are obviously not normal eyes. One misconception is that the BAD is not specific in itself for keratoconus. Again, it's designed for preoperative screening to separate normal from abnormal. It can be used to diagnose keratoconus with additional specific parameters. And again, an abnormal final D does not in itself mean keratoconus. But we're going to start off with some background, as I always do. The first thing we should understand is when we look at maps, we call them elevation maps. And we say this is the anterior elevation, posterior elevation. We're actually never really looking at true elevation maps. This is what a true elevation map would look like. The one on the left is a normal eye, the one in the center is mild keratoconus, and the one on the right is advanced keratoconus. And if you look at them, they all look pretty much the same, which is why we don't show raw elevation data. If you think about it, if you were to lie a patient down on supine and have them look up to the ceiling, the apex of the cornea is always going to be the high point, no matter how advanced the keratoconus is. So the maps look very similar. So we have to do something to allow us to visually tell normal from abnormal. But realize that's something we do to, I don't know if you would manipulate, but to display the data. But this is what you see right now is really what the computer sees. And the most common method to display elevation is to compare the raw elevation data against some common shape. And those shapes can vary. They can be spheres, torics, ellipsoids, they can be anything. But the most common shape used is a best fit sphere. As I mentioned, other shapes can be used, ellipse, toric, ellipsoid, but for general screening, a best fit sphere is the most intuitive and easy to interpret. Realize, contrary to what a lot of people will talk about, the reference surface has nothing to do with accuracy. If you had a building and you were to measure it from the street, you would get a certain height. If you would measure it from sea level, you would get a certain height. If you measure it from the basement, you would get a certain height. They're all just as accurate, but they're all different. So the reference surface doesn't affect accuracy. It just changes basically how the appearance, or in this case, the height. So these are two classic examples of elevation data against a best fit sphere. The picture on the left is a very typical astigmatic cornea, and the one on the right is what we call a positive island of elevation surrounding a sea of blue, and that's what we look for when we're looking for ectatic disease. So why do we see this astigmatic pattern? Well, that's pretty easy to interpret. If you look at that and you compare it to a best fit sphere, you obviously have a steep and flat meridian. The steep meridian will fall below the best fit sphere, so those numbers are minus, and the flat meridian rises above the best fit sphere. What you will notice is that basically the apex point, the two join, but the further you go away from the apex, the greater the separation from the steep and flat meridian. The degree that they separate is controlled by two things. One, the magnitude of the astigmatism, but also how far you are from the apex. And again, if you look at the picture here on the left, you'll notice that as you go out towards the periphery, the numbers increase. So it's very common, I hear people go, well, this has to be abnormal because I see a plus 25 or a minus 25. Well, that can be completely normal in an astigmatic eye as you get towards the periphery. And this is what we look for when we're screening for keratoconus. Again, we call this a positive island because you'll notice it's basically a positive numbers here surrounded by a sea of blue. Now, this is actually a patient scan, but you will almost never see a scan that looks this pure because almost everybody who has keratoconus also has high astigmatism. So you'll see these islands superimposed on an astigmatic pattern. But why do we get this pattern of a positive island surrounded by a sea of blue? Well, if we take to extreme and we just look at a cone and say, okay, what would the cone look like against a best fit sphere? So what we see here is the top of the cone is truncated. So you'll notice here again, this is all positive, and the center is the highest point, which is what you see here. And notice that as you go down the cone, you get to this point here, which is a sharp transition between positive and negative. And that's why you see this thin band of green, is 0. But what's important here is as you go further down, the deepest blue or the deepest ocean or the most negative is not in the far periphery. It's in that mid-periphery area. And you can see that here. The dark blue is here. It's not out in the periphery. So this is the derivation of those positive islands of elevation. The problem that we have is that the normal eye is aspheric. So a normal eye will show a positive island of elevation if you compare it against the best fit sphere utilizing the entire cornea. So you can look here. Hopefully you can all see my pointer. The black line is the shape of a normal aspheric cornea. The blue is the best fit sphere, and you'll notice exactly what we saw before. We have the truncated cone, because again, the normal cornea is aspheric, it's steeper in the center, and it's flatter in the periphery. So that's a problem because if positive islands show on normal eyes, then there'll be a high false positive rate. So what do we do to allow us to separate true abnormal from normal? So that was what happened when I showed you earlier, if we use the entire cornea. So if you use the entire cornea here, you'll see on the far right, the optical zone that we compute the best fit sphere is almost 12 millimeters. It's the entire cornea, and you'll see exactly what I just said. You see a positive island surrounded by a sea of blue. But as we shrink the optical zone, that we compute for the best fit sphere, again, remember again that the cornea is steeper in the center and flatter in the periphery. So as we shrink the zone that we utilize to compute the best fit sphere, we steepen the best fit sphere. And as we go down in size, you'll notice when we go from basically 12 to 9, we just still get a hint of a little bit of an island here. But when we go down to 7, it's completely masked. As it turns out, this was just done by a huge population-based, basically trial and error, that the optimal best fit sphere to separate normal from abnormal visually. I want to go again. A computer doesn't do this. A computer uses the raw elevation data. But for visual inspection, the optimal best fit sphere is computed from the central 8 millimeters, which hides the normal asphericity of the cornea. So if you use an 8 millimeter optical zone, you will mask the normal, you won't get a false positive, you'll mask the normal asphericity, and only true pathology will show a positive island. But is that really the best reference surface? So realize the best fit sphere is the average of both the high and low elevations, pretty much what you see here. Again, this is an ectatic cornea schematic, and you'll see again we have a positive island, and like I showed you before, we have that deep blue here in the mid-periphery. But is that the best way to look for ectatic disease? Really, the best shape would be something that mimics the more normal periphery. If we have a shape that mimics the more normal periphery, it would further accentuate the ectatic region. And that was the goal for developing what we call an enhanced reference shape. So the regular best fit sphere is calculated using all the data within the defined optical zone. And as I already said, that defined optical zone is an 8 millimeter optical zone. The enhanced reference surface uses only data outside of the cone. Basically, I'll back up a couple. Basically, what we talked about here, we're looking for a shape that follows the normal periphery, but is not influenced by the ectatic region. So again, the enhanced reference surface uses only the data outside the cone. Now, very often you hear people say, well, it's a 3 millimeter zone. Actually, the exclusion zone varies between 3 to 4 millimeters and is based on a proprietary algorithm. So I know a number of companies have tried to duplicate our work, but they just use a fixed exclusion zone, which is not what the BAD is. The BAD, again, has a variable exclusion zone based on a proprietary algorithm. And the exclusion zone was analyzed by analyzing, and this is unfortunately, this is hidden on my screen, well, by over 1,000 normal and keratoconus analyzing ROC curves. So if we look at it, this is an ectatic cornea with a best fit sphere. And this is the same ectatic cornea using that enhanced reference surface. And again, you can see it further accentuates the ectatic region. In other words, the elevation deviation off the reference surface is greater. If we do the same thing in a normal eye, because a normal eye doesn't have a significant ectatic region, the change going from normal best fit sphere to enhanced reference surface is very, very small. So let's look at some clinical examples. The one on your left is the back elevation using the standard best fit sphere. And most of you can see this would be a little concerning. It looks like there's a beginning of an island right over here. But look what happens when we use that enhanced reference surface. It becomes much more visually significant. Now, notice the elevation goes from basically 18 to 31. And again, I don't think anyone would miss this as a positive island. And you may have missed it over here. If we look at a normal eye, same thing. This is anterior elevation, best fit sphere. This is enhanced, no significant change. You'll notice there's no significant change. Posterior elevation, again, no significant change, which is what we want. We don't want to create false positives. when we studied that in a large population base, what we found was that normal eyes showed an average change in the anterior apex of less than 2 microns. Keratoconic eyes showed a change of over 20 microns. And that was the p-value greater than 0.0001. It was even more striking on the posterior cornea, where the average change in the apex and maximum elevation was less than 3 microns. And keratoconic eyes, spelling error, showed a change of 40 and actually 45 microns, again with a p-value of 0.0001. This is shown graphically. It becomes a little bit easier to appreciate that the green is the change in going from standard to enhanced reference surface and normalized, and the red are keratoconic eyes. So it turns out, if you just look at this, that the change in going from standard best fit sphere to the magnitude of the change to enhanced reference is very good at diagnosing or separating normal from abnormal. And that's really the derivation of the whole left side of the bad display. The right side, which I won't speak as much about because that was really Renato's work, is pachymetric progression. And what is pachymetric progression? It's the rate of change going from the thinnest point to the periphery. And this is an example. The upper pair are 2 eyes that would have the same apical pachymetry reading. So if all you had was an ultrasound, these would both look like thin, but otherwise they would look identical ultrasound pachymetry. But if you look at the rate of change on the upper left, and these 2 graphs effectively are just 2 different ways of showing the data. I always find the percent thickness increase much more intuitive. So that's really the one that I routinely look at. And what this is a 95% confidence interval, and it's the rate of change going from the thinnest point to the periphery. If you have a more rapid rate of change, the graph will go down. If you have a slower rate of change, the graph will be somewhat flat. And you can see this eye, the tracing is right down the middle. So this is an eye that's somewhat thin, but otherwise normal. Now let's compare the one on the right that had the same ultrasound pachymetry, but notice this tracing. It's well below that 95% confidence interval. This would be highly suspicious for ectatic disease, in spite of the fact, excuse me, that the 2 eyes would have had the same ultrasonic pachymetry reading. If we look at the ones below, you notice both of the PTI graphs show a flattening effect. And that's because these are eyes with endothelial dysfunction or corneal edema. We do know that when the endothelial doesn't function well, the first area that actually thickens is the center part of the cornea. So you lose the normal transition from thinnest point to the periphery. So again, you'll see here, this is an eye with actually gross edema. That line is almost flat. So there's really almost no change going from the thinnest point to the periphery because, again, the edema is usually in the center part of the cornea. So if you see a flattening of this PTI graph, it's worth either looking at the endothelium on cell amp, or if you have a specular microscope, I usually tell people they should actually do a specular examination. So that was kind of the background to the bad display. And this was the original, which now is, God, I don't even know how many years. Bill, are you actually on? Guess not.
I am, yes.
Yeah,
I'm guessing that was 2009.
Well, you know what? That was a stupid question for me because, oh no, never mind. This is the date of the exam and date of birth are the same, so that's meaningless. Yeah, these are at least 15 years old probably. But this was the original bad display, which is now we call Belin Ambrosio 1. And it has the same things I discussed. This is anterior elevation, posterior elevation with a best fit sphere. This is the enhanced reference surface. and this is the numerical difference between the two. These are Renato's graphs, and this is a corneal thickness map. But what you'll notice, since most of you are familiar with the newer versions, there's no parameters listed, there's no standard deviations, there's no overall reading to the map. The second iteration utilized 5 parameters. It used the anterior elevation change, which was called DF. Again, that's change going from the standard best fit to the enhanced reference, posterior elevation change, pachymetric progression, the actual thinnest point, and the location of the thinnest point. Each of these parameters were independently calculated based on established normal values. And the individual values were reported as standard deviations from the mean. They would change in color to yellow if you were more than 1.6 or greater, and they will change to red if you're more than 2.6 standard deviations from the norm. So you can see here we have a yellow on the front, a big abnormality in the back, pachymetric progression, thinnest point, and displacement are within normal limits. Then there's a proprietary algorithm that looks at all these values and comes up with an overall reading. So this is really what separates the bad from other commercial machines that attempt to duplicate it, that they don't have the proprietary algorithm to give you an overall reading. So again, here you can see the overall reading here would have been 2.45, which again is significantly outside the normal range. So again, we're still talking about the second iteration. Here is an example of minimal thinnest point displacement. You can see the only thing here that's yellow is the location of the thinnest point. It's slightly displaced, as you can see here, but the overall reading is very, very normal. As it turns out, thinnest point displacement turned out to be a very weak parameter and was subsequently removed from the algorithm. Here is more significant, now this is an example why, significant thinnest point displacement. Everything else is normal. The overall reading is still very, very normal. So again, you will see in the next iteration, there is no dy because it really turned out to be a very weakly predictive parameter. Here's a case of borderline posterior elevation, but still an overall normal reading. And again, it's not uncommon that you will see, you can even have reds, individual reds, and still get an overall normal reading. And I always use kind of glaucoma as an example for that, that if you have someone who comes in with a pressure of 22, yes, that's, quote, outside the normal range. If they have no family history, they have a cup of dis of 0.1, they have a normal visual field, a normal nerve fiber light, they do not have glaucoma. They just have a pressure of 22. So if you were to color that, that would be yellow. So you can have individual, but the overall reading, again, is a proprietary algorithm that looks at, originally in the second iteration, looked at 5 parameters. And here's significant posterior elevation. And there you can see it's significant enough that we do get an abnormal overall reading. And advanced keratoconus. This is actually a really good example of why we got rid of the thinnest point displacement. This is advanced keratoconus, which is the central cone. So you'll notice everything is very abnormal, but the cone is located in the center, so it's not really a displaced cone, and you have a very abnormal final reading. This leads to the Belin Ambrosio 3, which is the one you currently are utilizing. It has a new regression analysis and 4 additional parameters in addition to the 5. It looks at elevation at the thinnest point at the front, and that's shown over here. Elevation at the thinnest point on the back, shown here. It does show Kmax, but I will tell you, Kmax is a very weak parameter, but because people were so used to using it for cross-linking, we were asked to put it in. But it's almost like thinnest point displacement. It really is a very weak parameter. And then ART max, which is another pachymetric progression parameter. The other big change by going from bad 2 to bad 3 is we now have hyperopic data. And you'll see if we look on the bottom here, and I believe in the newest iteration, the newest software release, we don't call it normal anymore. I think it's called myopic. And then we have hyperopic. The reason for that I'll show you later, but there's a different database to compare against if your patient is myopic or if your patient is hyperopic. When we say hyperopic, that includes patients who are mixed cell. We also gave you the option to turn off the colors for the individual parameters, but you can never turn off the color for the overall reading. The reason for that is we obtained some requests from surgeons who said basically, look, the overall reading is normal, but it shows a big red over here or over here, and I don't want to be pulled in front of a lawyer who's going to go, well, doctor, isn't this highly abnormal? When it really isn't. So you do have the option of turning off the colors. I normally do not do that. And again, I said it's a new regression analysis. There was improvement in the area under the ROC curve, which I will show you later. So why did we add a hyperopic database? Well, if we look at the numbers on our myopic patients, if we look at the anterior 0.2 and 3 standard deviations with 6 and 8 elevation points over the best fit sphere. If we look at posterior, it was 13 and 18. But if we look at hyperopes, look what happens. The numbers increase dramatically. So hyperopic patients really have different normal values. And as I said already, we added 4 additional parameters, the hyperopic database, which you use in both hyperopia and mixed astigmatism. In other words, if any meridian is hyperopic, you should check off the hyperopic database. And most of you probably know that there's these little yellow triangles that if you right-click on them, it will open up a drop-down menu that will tell you what those parameters are. And this is not, but this is, what the regression analysis looks like. And again, that's proprietary to Oculus and to the BAD. So this is the BAD 3 on advanced keratoconus. Obviously, you can see here, everything is abnormal. You'll also notice that the DY is no longer here. Here you'll notice Kmax abnormal, elevation in the back, thinnest point. Basically, everything here is abnormal, and we have an overall reading that's more than 10 standard deviations outside the norm. People are confused that they think these are all the parameters. That's not. There are 9 parameters. We just can't fit 9 of them down on the bottom here. So these parameters also are entered into the regression analysis. So this is an example of why you should be using the hyperopic database. The part on the left here is a hyperopic patient, but we left checked off normal. Again, now it says myopic. And notice what we get. We get an overall reading of 1.66, which is yellow. But if you use the appropriate hyperopic database, suddenly everything is white, and the overall reading is well within the normal range at 1.38. So it's very important to make sure you're comparing it to the appropriate database. And here is just an example. As I said, you can turn the colors off like that. Some people, again, don't want to show a yellow or red in an otherwise, quote, overall normal reading. So the BAD 3 demonstrated incremental improvement over prior versions. And for those of you who are familiar with AUROC curves, it went from this dotted to the blue, which actually is very significant. It utilized 4 new parameters: elevation at thinnest, anterior and posterior, ART max, and Kmax. And it, not just the BAD 3, all the BADs demonstrates ability to detect early keratoconus and ectasia risk in patients that otherwise would be missed by conventional placebo technology. And again, this is a comparison of the BAD 2 to the BAD 3. And for those of you who are familiar, it is actually, once you get up to that 90%, 95%, it's very difficult to get improvement. So this actually is a significant improvement. So how do I put this into practice? First, you should all know the features of the BAD. The first one that many people overlook is this number here. This tells you how much of the cornea the machine was able to analyze. It's supposed to be 8, because again, if you remember, the best fit sphere is taken from the 8mm zone. If you don't have 8mm, you can't take data from the 8mm zone. You can see here, the diameter is only 4.54, and here it's 5.17. We'll discuss that later, but you should always look at these. If you see red, you really should attempt to have your technician or you repeat the exam. We discussed really the rest of these. These are all, again, the parameters, standard deviation from the norm. One thing I do want to say is the bottom, I don't want to call them maps. The numerical difference between standard, best fit sphere, and enhanced reference is not a map. And I've always asked them to kind of change that from a circle to maybe more of a graphical analysis. It doesn't depict shape, it's just a numerical difference. It really goes back to that graph I showed you earlier. That's really what it's showing. So don't look at this and think it's depicting shape. So as I said, it's optimal to have at least 8mm of coverage. The quality check, which is this area here, will turn yellow if it's less than 8, but greater than or equal to 7.5. I've actually never really seen a significant clinical misreading if you have at least 7.5. The quality check will turn red if it's less than 7.5mm of coverage. And as much as you can, you should attempt to repeat the exams. You might have to hold lids open to try to get at least 7.5. However, there are some patients that you cannot. And the one thing you can always look at, even if you have coverage that's not adequate. So if you really have a coverage here of only 4.54, really none of this is reliable any longer. But what you can do is you can look at that PTI graph. If you notice, this is a solid line that stays solid until you get to 4.54, which is here. Then it breaks up because the data is no longer reliable. But notice, at least in that first 4.5mm, it's already highly abnormal. So while this may not be reliable here, you immediately know this is an abnormal eye, and that's one of the reasons you're not getting good coverage. This is a very abnormal eye. So again, if you can't get adequate coverage, look at your PTI graph. That often can help you. And I said this already, that you may have individual yellows or red, but an overall final D that is within the acceptable range. You always need to use other information to make a final clinical decision at the age of the patient, the ablation depth, family history, and asymmetry. Just like in glaucoma, if you have a patient who has pressures of 12 in both eyes, not a concern. Pressure of 19 in both eyes, not a concern. But if there's 12 in one eye and 19 in the other, that is a red flag. So you should always look at the two eyes, and highly asymmetric eyes should be a red flag. So this is the part I always kind of hesitate doing. This is my practice patterns, my guidelines. They're individual. They may not be applicable to different geographic regions, ethnicities, or equipment utilized. These are my personal preferences, and many of them are not supported by defined studies. They're just what I do in clinical practice. So my general LASIK guidelines, I rarely do refractive surgery on patients under 21 years of age unless they need it for occupational reasons. I do not do LASIK with thinnest pre-op pachymetry less than 495. That's not apical, but thinnest point. There's no data to support this at all. There's actually data to not support it, but that's just my practice. I have not used ultrasound pachymetry for God knows how long, probably 20 years. I've also not used placido imaging for over 25 years. I actually started using elevation back in the 80s on a machine that's no longer clinically available. So it's been about 40 years since I've ever actually used the placido device. I really rely on the bad display. I tend to print out the format refractive just because people are used to seeing it, but 95% of the time I'm really just looking at the bad display. I use a minimal residual bed of 300 microns. It's based on thinnest pachymetry, the femtosecond setting. Originally, I used to use the interlace, where I found to be more variable than the wavelight. So I actually took the femto, the interlace setting, and added about 20 microns. With the wavelight, I just used the actual setting, and then I used a computed ablation depth. And I think 300 micron residual is not uncommon. Now, this is the part I hate to show, but people always ask for it. These are my general guidelines for LASIK. For patients less than 30, I want a final D less than or equal to 1.6. Between 30 and 35, I can go up to 1.8, 35 to 40, maybe 2, and over 40, 2.2. I'm more liberal in patients over 55 years, and obviously more liberal with surface ablation. Realize this will vary greatly by geography, ethnicity, and the equipment. I actually have what I call an age-adjusted final D, and actually you'll see at age 30 and 31, it's basically the actual reading. And as you get younger, you add to the final D, and as you get older, you can subtract from the final D. So I have what I call it, it's not on the machine, but an age-adjusted final D. As it turns out, and my numbers here were done with purely clinical experience. For those of you who are familiar with Renato's work with the TBI, the TBI has a number of biomechanical, but also has an age factor. And when I looked at my clinical age factor and Renato's TBI age factor, they actually parallel perfectly. So it's kind of interesting that my clinical age adjustment mimicked his progression analysis age reduction. So this was mine, and the others here are different parameters on the TBI, but all we did was vary age. So the slopes are identical, which is interesting. So I said earlier that the Belin Ambrosio display is for preoperative screening, not for post-operative evaluation. Why? Because obviously a post-operative cornea is abnormal. It doesn't mean it's pathologic, but it's not normal. If you do an ablation on a cornea, the cornea is no longer, quote, a virgin cornea. It's no longer normal. So the question then is, how do you detect early post-operative ectasia? Well, you can't look at the anterior surface because it's been surgically altered, and changes on the anterior surface, regardless, would be a very late sign. You can't look at the pachymetry map because, again, the cornea has been surgically thinned. You need to look at the posterior cornea because the posterior cornea should not be affected by anterior ablation. So if you want to look at the bad, this is the only part that you can actually look at. You can't look, as I said, at the anterior surface. You can't look at the pachymetry map. These will all be abnormal. You need to look at the posterior corneal surface. However, there's a problem with that. And that difficulty is if you don't have a preoperative map. This is less of a problem now because now the vast majority of refractive practices use some form of tomographic analysis. But if you went back a number of years, and if you see older patients, a lot of them were screened only with placido systems. And what you didn't know is if the changes on the posterior cornea were actually there preoperatively and were just missed, or they are true postoperative change. So again here, as I said here, you don't know if this ectatic change or was missed and was pre-existing. And that occurs if the prior surgeon just looked at the anterior corneal surface preoperatively. But again, this is not what you would want to see on a postoperative cornea. The best way to look for early post-refractive ectatic change is a little confusing, and it's with the compare two exams looking at the posterior surface. As I say here, its use, however, can be somewhat confusing. So this is the compare two exams. Here it's curvature, And this is a normal pre-op, post-op, and you can see the flattening effect. If you look at the back surface, however, you'll notice on curvature, there's very little change, and that's because one is you don't expect to see change on the back surface of the cornea. In addition, if you're looking at curvature, don't forget the curvature of the posterior cornea is a low power minus lens. So even a change that you'll be able to pick up on the anterior surface in curvature can be masked on the posterior cornea because, again, it's a much lower power. Because, again, we're not dealing with an AF corneal interface. We're looking at index of refraction that's similar between the cornea and the aqueous. So the best way, again, is not to use posterior curvature. Again, as I say here, the posterior curvature is a low power minus lens. And it's not centered because, again, it's a low power lens. So that's why you should look at elevation, because elevation is independent of the index of refraction. So here you'll see, compared to exams, back elevation here, and then the difference. But what you will notice, and this is why I say it does get confusing, notice the best fit sphere on the first map is 6.31, and in the second map it's 6.40. So the two reference surfaces are actually different. Well, if you really want to see change, you want to use the same reference surface. And you can do that, again, you right-click over here, you'll get a drop-down menu, and you'll see this little box that says Change Reference Shape in all exams. If you click that, if you click that, this is what happens now. The two reference surfaces become the same. And why is that important? Because if you go back to the first one, notice there's very little change shown here. But when we use the same reference surface, notice we go up to +9. So it's a little confusing, but that's probably the most sensitive way to pick up early ectatic change post-refractive surgery. So in summary, the BAD 3 allows for high specificity and sensitivity. Additional testing with other devices is not only not necessary, but often confusing. You always need to look at other information. I kind of said this already: age, ablation, family history, stability, and always compare both eyes for symmetry. And I'd like to thank you for your attention. We do have a few minutes left if people have some questions. I don't know if they're set up for questions or not.
We do. We have a chat function. Anyone has any questions, they can enter them into the chat function. Michael, I have a question about the last topic you just went over. It is somewhat complicated of making the best fit spheres match when you're doing a difference map on the back elevation. Does it matter, though, whether you choose the flat or the steep to make it match?
I always use the earlier one. I haven't, because nowadays, to be honest with you, there's really very little post-LASIK ectasia relative to what it was, years and years ago. So I don't have a large enough database to really tell you that. I just routinely use the earlier one. It's a good question. I've always thought that myself, but I really do not know.
Yeah, I've played around doing both ways, and I haven't come to a conclusion if it really matters.
Yeah.
How many microns is your cutoff of significance on that difference compare map? You mentioned 9 microns.
Bill, are you going to keep asking questions I can't answer? I'm kidding. The answer is I also don't know. Our database of recent post-LASIK ectasia is so minimal. The reason why you have to have recent is because you have to have ones that were imaged on a Pentacam. And truthfully, there are very, very few patients who were properly imaged and properly read on a Pentacam that went on to develop post-LASIK ectasia. I'm actually only aware, I'm sure there's more than that. I'm only aware of 2. Now, there are many who people misread. They should never should have surgery to begin with. But I've only seen 2 patients in all the referrals I get and the maps I get sent where I thought the preoperative map was reasonably acceptable. And that's over, 15, 20 years.
I have a question from the audience, and it has to do with curvature indices, which I know your answer to, but I want you to answer it. How important to you is the IHD index for screening patients for keratoconus or abnormal corneas?
I don't have a problem if people look at it. Many years ago, I won't mention who. There was a speaker at a conference and basically said IHD is 100% accurate, and I just went in and I showed him a bunch of maps where the IHD was abnormal and the bad was completely normal. It's a good parameter. I think you can look at it, and if it's abnormal, it is at least suspicious, but it's not necessarily specific. It is sensitive.
But not specific.
Correct.
Excellent. Another doctor is asking, can you go back to the slide and show us where you clicked on to change the diameters to make them match? Can you go backwards?
Yeah, you can't, you just, if you, I don't know if you, can you see my mouse?
Yes.
Okay, if you, it's hidden. If you put the mouse over here and just right click, this will open up. And then you just click on change reference shape in all exams.
And you can right click over the best fit sphere either on the first map A
right.
or
If
the
you
B
do it
map.
on the first map, it'll use the first map. If you do it on the second map, it'll use the second one. So here, because I'm on this one, if we back up one, you see this is 6.31. So I'm going to, if I right click on that, I will get that.
There you go.
And then I check on that. And then if you notice, now it's 6.31 on both. If I did the same thing on the right one, it would be 6.4 on both.
Excellent. I've got another excellent question from a participant. Could you talk a little bit about your values that you look at in Final D as far as considering cross-linking?
Yeah. So I am Chief Medical Officer of a company that is going to be starting very shortly our phase 3 on Epi-on. We use parameters from the Pentacam, but as I said earlier, the bad by itself doesn't diagnose keratoconus. So you have to, an example will be, you have someone comes in your office with gross corneal edema, the final D will be abnormal. That's not someone you cross-link. So you have to look at the D, you have to look at pachymetric progressions, you have to look at the posterior elevation values to make a diagnosis of keratoconus. I stressed very earlier, the bad separates normal from abnormal. Again, you have someone comes in, post-ablation, but otherwise stable, they will have an abnormal D. So you have to look at a number of parameters that are specific for keratoconus.
Another question just came in. Do you have a personal recommendation for the maximum ablation depth for PRK?
I actually used to approach it slightly differently. On surface ablation, again, I want to stress these are just my personal preferences, that I would not ablate a surface ablation to a cornea that would end up less than 400 microns.
So that's your final, okay. Can you comment on PTA?
Yeah, and actually PTA is not really, and actually Santiago actually agreed about this. It's a surgical planning, it's not really a screening. So I do look at it, and I do abide that I don't ablate more than that, but it's a surgical planning, it's not a screening tool.
Excellent. I think that is all of our questions we've gotten tonight.
I want to thank everybody.
So much. Yes, what a fantastic job. I always learn many things when I hear you talk about this subject, so thank you again for explaining it so clearly. And thank everyone for attending tonight. And if you have any additional questions, there are email addresses you can send questions to, and you can even add more questions in the link we'll stay on, and we'll monitor the questions and we'll answer them via email.
Good night, everybody.